good afternoon. So now I'm here to just enlighten the overview of the fistula management. My keen interest was a laparoscopic surgery and robotic surgery. Since 14 years, I put my heart and soul to the laparoscopic surgery. But in my practice, I realized that proctology is the most important aspect of a general surgeon. Not only it's a bread and butter, it's a biryani. That's what I realized over a period of 5 years. In Bangalore, cities like Bangalore, the people started their own laser treatment companies, and they started promoting in a different way. When they are doing, why can't we? That's what made me to think seriously about the proctology. Then we started working towards developing the proctology, training, teaching and research. So fistula is one of the most common surgery we do as a general surgeon, but to do a fistula, to prevent the recurrences and deal with the complexity, we need to know the basics. So we are going to deal fistula in these topics: anatomy of the anal canal, ischiorectal abscess, fistula in proper. You know the definition. So fistula is a abnormal communication between the anal canal and the external skin. Most of the time, it is a 40% due to a previous sepsis, either perianal abscess or cryptoglandular abscess. Etiology: non-specific causes is cryptoglandular in origin, and specific causes like Crohn's, ulcerative colitis, TB, and so many causes like this. As a classification, we routinely follow this: intersphincteric fistula, transsphincteric, suprasphincteric, extrasphincteric. Based on the opening, we can classify this as a low type, high type, and also a simple or complex. As you know, the Gussel's rule gives a idea where is the internal opening and where is the external opening. There are some deviations for the Gussel's rule as well. So the history is very much important in a patient with a fistula. Usually the patient presented with a previous history of a drainage for the ischiorectal abscess, or previous history of perianal abscess, or pruritus ani, or a pus discharge in the anal canal. And also we need to keep in mind the differential diagnosis like tuberculosis, Crohn's disease and other fungal infections as a secondary causes for the fistula. What are the most important aspect in clinical examination? We need to define where is the internal opening, where is the external opening, is there a primary tract, is there a secondary tract. These are all the definition we have to give on paper in clinical examination. For that, we may need a proper clinical examination by digital rectal examination and proctoscopic examination, followed by a video rectoscopy can be used, and sometimes the sigmoidoscopy is also very much important to rule out the diseases like Crohn's disease and ulcerative colitis. We practice the endoanal ultrasound and limited sigmoidoscopy for most of the patient which has a recurrence and complexities. So endoanal ultrasound in our institute, I learned endoanal ultrasound. I do endoanal ultrasound for myself. I will plan the treatment accordingly. So for us, endoanal ultrasound is one of the basic clinical examination kind of thing. So that gives a fair idea what is the collection, which space the collection is. As already discussed, MRI, we consider MRI for recurrent fistula, complex fistula and high anal fistulas. We order MRI scan, and personally I discuss with a radiologist how to go about. Otherwise, I don't accept any MRI scan just by a report. So rightly said madam in the morning, just reporting, even in Bangalore, only 3 centers, they are doing a endoanal ultrasound. 1 or 2 diagnostic center, they report the MRI scan. That is the difficulty of reporting MRI scan even by the radiologist. That's why I made a practice that I always discuss the internal opening, tracts, all those things with the radiologist, then only will take a decision for the plan of treatment. So treatment, the key principles, obliteration of the internal opening and adequate control of the sepsis by proper debridement and drainage of the napsis, and sphincter, management of the sphincter is one of the key principle in management of the fistula. If, as you know, if less than 30% of the sphincter involved, we can cut open, and if it is more than 30%, we have to save the sphincter. But there are dozens of fistula surgeons here, they are going to speak how to cut open the complete sphincter and repair it. So that's what they are going to present it. So this is the standard way of teaching to save the sphincters. So the most important aspect is biopsies. Biopsy, we should not forget to send all the tract curettage for the biopsy to rule out the malignancies and also to rule out Crohn's disease. And also we have a special interest with the histopathologist. We are going to send all the tract, and we are going to give advise them to do a immunohistochemistry to know what may be the exact pathology of the fistula. These are all the common treatment, as we know: fistulotomy, fistulectomy, statins for some patients. These are all the other advanced treatment. So lift, waft, all other procedures they are going to explain in the next sessions. My topic of interest is I am going to deal with the fistulotomy, fistulectomy. Fistulotomy, as you know, lay open the tract based on the whether it is a transsphincteric, intersphincteric, or a low perineal fistula. Fistulectomy, excising the fistular tract proper. There are basic demonstration. Voice. So even after anesthesia, a proper perineal examination defining the external opening, internal opening is very much important in the treatment of the fistula. Most of the time, there may be two internal openings. We may miss one of the internal opening which may be higher. That's why I practice doing a colonoscopy and video rectoscopy and proper examination to see the internal opening and injecting the dye, methylene dye, sometimes mixing methylene dye with hydrogen peroxide that delineate the tract properly. So this is one of the common procedure, like the external opening at 5 o'clock. I'm injecting the dye. Lithotomy position. This is lithotomy position. The video, so introducing the probe. The most important aspect is we should not put a pressure. We should not force the probe. Otherwise, it will create a false tract. This one. Next video. This is the fistulotomy. Next video. So this is a curettage of the fistula tract. So these are all the key principles in a fistulotomy. Curettage is important, identifying, fistula probing, and injecting a methylene dye. Sometimes I use laser probe to ablate the fistula tract after curettage. So this is one of the transsphincteric fistula. I have done apply only setan and curated complete tract. It's a recurrent fistula for a patient with immunosuppressant. He's a post-renal transplant patient. He underwent 3 surgeries. So the MRI scan shows there is a loss of sphincter. That's why we don't want to do any major procedure for him. So we applied a satan and curate the tract completely and ablate with the laser. So yes, recovered. Yeah. Give me fast forward. The previous one. Is one of the perineal abscess. In a patient with a perineal abscess, it is always a principle to look for an internal opening. If it is an internal opening, after opening the abscess, so better to tackle the fistula as well. Yeah, this is how I think I wanted actually. Yeah, this is one of the concept in always while doing a fissurectomy. In a clinical examination, if the patient with a known case of fissure, he has a continuous pain in the whole day, our experience shows that there will be a sinus. That we advise the sonologist to diagnose it. There may be a sinus. So you used to give the report like there is a collection of the pus. So I'll always make sure that while dealing with the fissure bed will have a sinus. With a right angle, I'm going to do a sinusotomy. So that prevents the future infection in a patient with a fissure surgery. In a clinical examination, you can see there is a fissure bed. Yeah, you can see just a right angle I used to enter into the sinus. I'm going to do the sinusotomy. Yeah, and curate the tract. This one patient presented with a trauma, a self fall, had a perineal hematoma. Then she presented with a fistula. So when the fistula internal and external opening in abnormal position, we need to suspect the other causes. In this patient, the internal opening was at 10 o'clock. Previously, 1 month back, they have diagnosed this an hematoma, perineal hematoma. That perineal hematoma leads to a abscess, then leads to a fistula.